know, there's a lot going on this morning. I apologize for us competing with other news events. This was something that it's a change, a positive change we felt we had to make. We were finally ready to make it, had to make it, and we've done it, and we wanted to explain it. And so that's why we're doing this at this odd hour of 9:15 in the morning, and that's why we're doing it in such a hurried fashion, because new numbers have just been posted at 9 a.m. and we didn't want too much time to pass without an explanation of why things are just a little bit different this morning. And so let's see, I see one message in chat. Okay, I think everybody's got permission, so I am told if anyone does not, now is a good time to speak up. If you do not have the ability to record, please let me know, and we'll change that. Also, we are going to record this at this end. We are recording it at this end, and so we can make that recording available to anyone who cannot join us. All right, so again, thank you very much. Introduce myself, and I don't think I need to introduce the person who's going to talk to you today. Our state epidemiologist, Dr. Sarah Kemble, is going to talk to you about the reactivation of the Hawaii Immunization Registry. It's actually been up and running for quite some time, but we are now moving all of our data, COVID-19 vaccination data from the vaccine administration management system over to the Hawaii Immunization Registry, and that's going to do some positive things for us. And as it pertains to COVID, it's going to give us some really more accurate data, and it's also going to improve patient care. So here to talk more about that is our state epidemiologist, Dr. Kemble.
Thank you, Brooks. Thank you for joining us this morning for an update on COVID-19 vaccination data and the Hawaii Immunization Registry. We're announcing today that we have reactivated the Hawaii Immunization Registry, or HIR, to track COVID-19 vaccines. The numbers you see on our COVID-19 data dashboard now for the first time come from the Immunization Registry. The Immunization Registry is a statewide information system operated by the Department of Health that stores and tracks patient immunization records. A record of polio vaccines, tetanus vaccines, measles, and mumps vaccines, and other vaccines are kept in the Immunization Registry. And now COVID-19 vaccination records have been moved into the Immunization Registry as well. Getting the registry up and running is good news for a lot of reasons, but before we get into the long list of benefits of having an immunization registry, I'd like to give you a little history on the registry. In 2019, we recognized the immunization registry needed to be updated to be fully functional. Then, while we worked to rebuild the registry with new servers, new software, and new licenses, COVID-19 hit. Thankfully, the CDC developed the Vaccine Administration Management System, or VAMS, and we have been relying on VAMS to record and store COVID-19 vaccination data for Hawaii. VAMS is not a perfect system, but it enabled us to track vaccinations while we raced to get shots into arms. Once the registry was outfitted with new servers, new software, and new licenses, we began to transfer COVID-19 vaccination data from VAMS to the Immunization Registry. That work is ongoing, but we have done enough that vaccination providers are now entering COVID-19 vaccination information directly into the Immunization Registry. And the vaccination data you now see on the COVID-19 dashboard is pulled from the Immunization Registry. There are a lot of advantages to having data stored in the registry. First and foremost is the fact that the Immunization Registry documents an individual's immunization history. Because the Immunization Registry tracks an individual's immunization information, healthcare providers can access their patient's history. Providers can see where a person was vaccinated, when, what product they were given, and what dose they received. This improves patient care. It allows healthcare providers to determine when a person is overdue for vaccines and helps avoid redundant vaccine administration. VAMS is not an immunization registry and doesn't have the same level of detail. Providers using VAMS can only see the vaccinations they administered, not all details of shots given by other providers. Because the immunization registry contains an individual's vaccination information, we can find accounting errors. For example, the immunization registry will prevent the duplication of records. Duplications are vaccinations that were counted twice. In the registry, we can see a person who received a single shot on a particular day at a particular location with a particular product may have been counted as having received 2 shots. This double counting skews our data, but is flagged through the immunization registry, and as a result, we get cleaner, more accurate data. Here's another example of an accounting error that is corrected thanks to the immunization registry. A vaccination provider who gives a person a booster but didn't give that person their first 2 shots may mistakenly record the booster as a first dose rather than a booster dose. This skews our data collection. VAMS was not able to identify this kind of mistake, but because the immunization registry catalogs an individual's vaccination history, it looks at that person's history, spots the error, and allows us to correctly categorize the booster shot as a booster shot and not a first dose. The immunization registry also allows us to better determine where a person lives. It helps us spot visitors who were vaccinated here and allows us to remove them from specific data sets. Bringing the immunization registry online will also help us to resolve the long-standing discrepancies between our vaccination data and the data CDC has been reporting. So here's a look at how some of the numbers are changing now that we are reporting data based on records stored in the Hawaii Immunization Registry. I'd like to reiterate that the transition to HIR only affects vaccination data, not case or testing data. So there's little change in the total number of vaccinations administered. We have still administered more than 2.3 million vaccinations. Our improved data shows 71.1% of Hawaii's estimated population has completed its primary series of vaccinations. Again, this is just residents. We've removed identifiable visitors who listed addresses outside Hawaii and removed duplicate records. We have also been saying publicly that we know that the number of initiated doses was inaccurate. This data on initiated doses is more accurate in HIR. 77% of Hawaii residents have initiated vaccination. Many third doses or booster shots were mistakenly reported as initial shots. This is reflected in the updated data on booster shots. The improved data from the immunization registry shows 228,892 people have already received their third doses or booster shots. And we talked about getting the CDC numbers in line with our numbers. The CDC shows only 60.7% of our residents have completed their primary series of vaccinations. Our numbers more accurately show that about 71.1% of residents have been fully vaccinated. The CDC will now be able to pull data from our immunization registry to accurately compare Hawaii's numbers to the rest of the country. The CDC's revised data will show Hawaii ranks in the top 10 states instead of being in the middle of the pack. So a few points I want to make in conclusion. One is that other states are undertaking similar data improvements. This is not a practice specific to Hawaii. We're making this change now because DOH is committed to making systematic improvements to modernize systems and improve our healthcare infrastructure. Public health is chronically underfunded, but now we have an opportunity to ensure that these critical systems are updated and available to help us protect Hawaii residents. Throughout the pandemic, we have always emphasized that completing the primary vaccine series provides strong protection against severe illness, hospitalizations, and deaths. What remains unchanged is that more than 1 million Hawaii residents have made the decision to protect themselves, their families, and their communities through being fully vaccinated. The numbers you see today reflect a more accurate picture of how Hawaii is doing in regard to COVID-19 vaccination. And the bottom line is we're still doing well. Thank you.
Thank you, Dr. Kemble. Let's open it up to questions from the media. You guys are always great at just kind of firing away in an orderly manner, so no need to raise your hand. Daryl Huff?
Yeah, can I ask, why did it take so long? I mean, what was the holdup? It seems like, from what I understand, it's been down since the beginning of the pandemic all the way up to now. Is that correct?
Correct. So the process is a long one because it involves not just setting up and establishing the changes in the system that were needed, but working with each provider that contributes data to the registry to make sure they are ready and able to transmit their data accurately and correctly. So it's a process that involves working back and forth with providers. And that's a lot of the time that is involved.
So every doctor's office, does it go down to that level of specificity?
It can. There are, in health systems, there may be some consolidation of the information technology systems. And so we can work with IT staff for a large health system and cover a lot of providers at once. But there are many smaller providers who need to work with us one-on-one as well.
My last question is, are you now able to break out minority groups and by ethnicity when it comes to vaccination?
We have, with the transition, gained a lot more completeness of race and ethnicity data. So we're better able to represent more people who were vaccinated in terms of race and ethnicity. We are still at this point limited by how those electronic messages get bundled and sent according to CDC standards. So we continue to work with the CDC on the topic of disaggregation to see how much more detail we can get in the race data that are transmitted.
Okay, so basically though, does that mean that you can or cannot yet, say, break out Native Hawaiians from the Pacific Islanders, for example?
At this point, in the ways that we receive the data into the registry, we cannot break that out for all people. We have some subsets where we've looked more closely, where we have that level of data from certain providers, and that's enabled us to make some estimates, but we don't have that for all comers in the registry at this point.
Can you talk about why it's difficult to have that data and you'll be able to separate it out? I know that's something that DOH has prioritized since April 2020. So why is it not possible here?
It's the challenge is that you're really having to address this issue at every point along the way in a complex system. So we now have forms for how we would like to receive the data, which are shared at the starting point, which is the providers who collect the data in the first place, or sometimes even the person who may be entering their vaccine information. So step one is making sure it gets represented in that form that somebody fills out when they go to get their vaccine. Step two is that the provider's electronic system can capture the data in the way that we would like it to be captured. So some electronic records can do that, some cannot. And then finally, the standardization of those messages is something that's guided by federal standards, and federal standards haven't prioritized that level of disaggregation up to this point. So that becomes a national level conversation to discuss why those standards should include greater detail and disaggregation. So if we can accomplish those things at all the steps along the chain, we would be able to get the quality of data that we would like to get to analyze it.
Is that true then as well for the Filipino community? Because I know that they've been really, eager to see vaccination data. Is any disaggregated data for them going to be available in this new database?
The categories offered in the HIR right now are still limited to the Asian category. So we don't see that level of breakdown. So it's the same approach we've taken with Native Hawaiian populations to work with limited data sets that we do have access to try to understand that better.
Dr. Kemble, the press release says that the registry was under repair when the pandemic began, but how long was it down for or inoperable for, and why why were you guys caught sort of flat-footed on this? I mean, why wasn't it repaired earlier before it got to the point where it was inoperable?
The registry was inoperable from 2019, so it's been several years. The first step, of course, was getting it sort of basically like when you have a car breakdown and you want to open up the hood and figure out what's going on. So we took those first steps to understand what were the issues and realized that there were a lot of infrastructure developments needed. So a lot of modernization, changes to software, changes to platforms, even to the ways in which that entire system was set up. So that rebuilding took time. So during that time, we assigned a team. We also realized we didn't have the existing skill sets to build what was needed. So we had to create and assemble that team to tackle that problem. That team's been hard at work throughout the pandemic, realizing how important this was. At the same time, we had to make that decision as vaccines began, and we felt that using VAMs was going to allow us to continue the work to rebuild the registry as it needed to be, while still capturing the core data that was needed on vaccines. So there were some trade-offs in that choice, but that allowed us to move forward and get to this point where we can finally make this transition.
I just wanted to clarify though, it was inoperable in 2019 when the pandemic hit, but had it been inoperable for years prior to that? When was the last date that it was sort of working?
Right, so again, in the timeline, we had a few outages in 2018 that were temporary and able to get back online, but in 2019, it was taken offline to basically be put under construction because it was really decided that it was beyond repair. So it's been since early in 2019 that it's been not functional for most purposes interfacing with providers.
Are all of the vaccinations up to this point, boosters, is all that information in the system already, or are there still more that need to be added that could be changing the numbers we're seeing today?
I would say we're about 95% of the way there. We're continually improving the process and continually working with providers to validate their numbers. But at this point, we have the vast majority of providers that had reported doses in VAMs now at reporting doses into the registry. And for those few that couldn't make the transition yet to HIR, they are still able to enter doses in VAMs, and we can still transfer doses from VAMs into the registry. That being said, it's a continual improvement process. So we'll be continuing to look at how we can improve upon the validation processes and make sure those numbers are as accurate as we can get them.
For residents that I guess have moved away in the past year, and then vice versa for people who have moved to the state and maybe weren't vaccinated here, how do those numbers end up getting updated with this system, if at all?
We wouldn't necessarily be aware of doses given outside of the state. Those wouldn't typically get reported to the registry. So those would not necessarily be updated. This system does do quite a good job of capturing most of the doses given within the state of Hawaii.
Okay, thank you.
Sarah, the use of this data by your department, what is the biggest benefit that you see getting out of this to your department in terms of either outreach, maybe access to safe travels information for residents trying to return, that sort of thing? What is the biggest positive impact from having this data now, other than just having the data?
I think one of the biggest benefits is it really, as intended, allows the health department to work in partnership with our healthcare providers to improve healthcare for all. So it's really, this allows now healthcare providers to, once they're enrolled, to access immunization registry data so that they can, if they have a patient sitting in front of them today, they can know that, okay, this person did miss their second dose or they're behind and they're overdue for it. And it might not be COVID alone. It might be this person missed their dose of tetanus, and those kinds of things can really help providers to make sure they're providing the best possible care to their patients. In terms of COVID, it allows providers to work together with the health department to identify gaps, to say, these are the patient populations where we see that not everyone has had their doses yet, and they are in our system, our patients. So we can do that outreach to them as their personal provider and have that conversation about getting vaccinated.
One last question, sorry. On the Omicron variant, I know this is kind of a laboratory question, but can you tell me what the length of the lag would be between a positive test that would be discovered in your surveillance system? How much time that would take from the positive test to discovery in the surveillance system if it becomes part of the surveillance survey?
Sure. So it's a bit of a change in topic. So Omicron and the reporting of potential positives that might be Omicron doesn't happen through our registry system, but that is through a different information system that the health department operates, and that's through our electronic laboratory reporting. Omicron is relatively new. Lots of talk about it in the last few days and week. It does have one feature that may make it more easily detectable here. And that is that on some of the tests that are still commonly used for PCR tests, it has a dropout in one of the targets. So it's called an S target dropout. We talked about this before last year when we were concerned about the B117 variant from the UK. And at that time, we were able to scan for that variant by looking for S target dropouts through our participating laboratories. So we've put up the same, call to all of our participating laboratories to say, if you see specimens with S target dropouts, we want to hear about them right away. So those are coming into our state laboratories division, and Dr. Desmond, the administrator of the state laboratories, is very much in contact with all of the laboratories to stay on top of that. We would immediately sequence specimens that are coming in as S target dropouts. We haven't seen a lot lately because most of our virus has been Delta, and Delta does not have that S target dropout feature, which actually puts us in a better position to detect this new variant, because should we see one, it would be something that would immediately be raised to a level of concern.
And how long does the sequencing take at that point?
Sequencing after an S target is identified still probably takes about a week on average. We do have some more rapid technologies, and I'll defer to Dr. Desmond to give you more detail on that. So we are getting faster at doing that turnaround, but at least with that molecular clue, the epidemiology team can jump on that case right away and prioritize it for contact tracing.
Thank you. I appreciate you taking the question off topic, but that is like the topic right now, so I appreciate it.
Dr. Kemble, do you now have clarity as to why the CDC and the DOH figures have on fully vaccinated residents have differed so substantially over the months? It's like a 2 percentage point spread. And now that you've sort of gotten better data on the state end, is it clear what had created those errors?
Yes. So the CDC is typically pulling the data that it shares in the national dashboards from other immunization information systems like the Hawaii Immunization Registry. Because ours was not functional, we had crafted a system that was a combination of data sources. They were looking at data from BAMs, but also through some of their federal partners and other data sources that they were able to access. However, in patching together those different data sources, they don't get individual level data. So you're really looking at aggregate numbers and trying to make sure you're not overlapping them. And in that process, it ends up not being incredibly accurate. So CDC had been aware for some time, for months, that the data that they were representing for a state of Hawaii was not accurate. However, what they needed to fix the problem was a comprehensive data set from the Hawaii Immunization Registry. With that now available, we're able to work with them to fix those numbers and get them in line with what we are now reporting. And we both know that would be a more accurate representation.
And so just one other question, when did you, the significant differences seem to be between the percentage of people who have initiated vaccines. When did you realize that that data was incorrect?
We've been talking about that for several weeks. As we see with the age data in particular on the data dashboards, we're sharing with you what we have in our data set. So we see, as many people in the public have also commented, that you have some age categories exceeding 100% or up at that 100% line. That doesn't make sense. We know there are still some people in those age categories who remain unvaccinated in the state. So that's something we've been aware of, but realizing how we needed to fix it really hinged on being able to do the kind of deduplication that the Hawaii Immunization Registry can do.
And sorry, one other question in regards to the other diseases that are recorded in this immunization registry. Will any of that data now be public, to sort of get a sense of how well our population is protected against other diseases, and how will that data be used exactly? Is it just internal with DOH and providers, or will it also have a public interface?
The primary use of those data prior to the COVID-19 pandemic really has been more focused on the healthcare systems and providers being able to provide the highest level of care. So that's been the emphasis. I think that the COVID-19 pandemic has shifted both capabilities and interest from the public to understand some of these trends, like how well vaccinated are our populations. We have historically shared data that we collect from schools on vaccination coverage within Hawaii schools, but not necessarily for population level coverage rates. We do this through national collaborations with the CDC. So there are data on some of the CDC websites on estimated vaccination coverage by state. And that does come from utilizing data in immunization information systems. But I think going forward, it's definitely an area to explore what else would be valuable to share publicly, and something that we hope to be able to work on post-pandemic.
Thank you, Dr. Kemble, and thank you, reporters. Any last questions on Omicron or the Hawaii?
Hi, Brooke.
Yes.
Sorry, thanks for asking that. I just wanted to ask one more about Omicron. Dr. Kemble, do you mind kind of sharing how you're feeling about it? I mean, we spent the whole weekend reading these crazy news stories nationally, internationally about borders shutting down. How worried should people in Hawaii be about it? Do we know whether it's here? I mean, it sounds like not yet, but could you confirm that and just let us know what your thoughts are about it?
Yes. And just to answer your last question first, we have not had any reported cases of Omicron in Hawaii at this point, nor are we tracking any S-target dropouts that we would be concerned might be Omicron at this point in time. And also nationally, I had confirmation from CDC this morning that we have yet to identify a case of Omicron in the United States as of today. Now, I think what the public health world is concerned about here is with even just these clusters being reported out of several countries, it is likely, as we have seen before, that it is already spread farther than we have yet to detect, right? So I think that we're all looking to see how can we buff up surveillance to make sure we're catching it when it appears. I think there's really two things that make this Omicron variant concerning. One, as with every new variant that has emerged, is that we know so little about it. And what we know so far is that it has a large number of mutations, including in the spike protein domain. And that raises concern because that's how the virus finds its way into our body. So by mutating there, it may be finding new ways to infect and transmit. And that's the potential concern. But I do want to remind everyone, as we've seen with other variants, we have yet to know what the actual practical implications of that are going to be. There is some concern that it may be more transmissible because we're seeing it begin to emerge in areas that were already dominated by Delta. And Delta was known to be very effective at transmission. So perhaps seeing outbreaks of this new variant means that it may be also highly transmissible. We don't yet know a lot about how dangerous it is to people. Does it cause similarly severe disease, more severe, less severe? Those are questions that all state epidemiologists are asking right now and anxious to know. The other thing that I think raises concern about this variant is that it exposes a weakness that we have had globally since the beginning of this pandemic. And that is this virus has found ways to transmit through human populations. And the best way to fight it is really to come together globally within our communities, within our state, within our communities. And it really exploits any divisions that we have within those systems. So when there are health inequities, when there are gaps and pockets in which there are large numbers of unvaccinated people, that's when these variants really exploit and can transmit rapidly. And I think that's a lesson we really need to learn from this pandemic, that we have to pull together to stay on top of this and make sure that we don't become victims again to having widespread transmission in areas where we perhaps could prevent it by pairing vaccination with the mitigation measures that we already know so well. So this is really a time for us to come together.
All right. Last call, everybody. Omicron and Hawaii Immunization Registry. Looks like that'll do it. I will be, of course, available. Should you have follow-up questions, you can send them my way. You all have my email address. If you're looking for specific numbers or you have questions, I will do my best to get you the answers. Dr. Kemble, thank you very much for taking the time this morning to talk about this very important change. We look to, we're all excited about, numbers being as accurate as they possibly can be, and better patient care. So two real big positives out of this morning's announcement. Be well, everybody. Get yourself your boosters if you haven't already, if you're eligible, and mask up indoors. The holiday season is upon us. Thanks for taking the time. Be well. We'll talk to you soon.